Hi, everyone. I see people are joining in. Let's give it another 15 seconds so people are in and settled, and we'll get this dev chat kicked off. Okay. I think I see everybody is in and settled, so let's get started. Thank you, everyone, for joining in for another edition of dev chat. As most of you know, we are very excited to host these events. These are our community events for all of us to connect and discuss with each other, share some wisdoms share some nuggets of wisdom and learn from each other. Yeah, with that, let's get kicked off with our June edition. Our Yeah, can you go to the next slide, Dennis? Yeah, so quick update before we get started. Add questions in Q&A anytime, raise hand, and unmute yourself when called. Session recording will be available on the AMA Intelligent Platform site. Those of who are part of the developer program already know the website for AMA Intelligent Platform, and we'll share the links. And we'll discuss a lot of feature, but no definitive feature timelines unless explicitly stated. With that, really excited to get things rolling. Next slide. So today's topic, Dennis will be at a high level covering CPT developer program updates. And this is CPT Dev Chat. So really excited to bring you yet another exciting guest joining us today, Ed Simcox. Very briefly, most recently, he was the VP of Solutions at Mayo Clinics. And previously, he has served as the CTO at US Department of Health and Human Services. He's renowned for his leadership in health IT and policy development and digital health innovation. And I'm just so thankful for him to be joining us today. And Dennis will do a detailed intro, but I am really just wanted to extend my sincere gratitude for him being here and being available to this community. So thank you, Ed. And to wrap it up, we'll be just talking about some participant use cases and questions. Those of you would like to share their experiences, you're welcome to. With that, let's get going.
All right. Before we jump into updates, we'll run a quick couple of polls. So we'll start poll number 1. We'll just get a sense of who's in the audience. So the question is just basically, are you, in the dev program, a dev licensee, a CPT licensee, or just popping in? We'll give you a few seconds here. Just a couple of poll questions before we dive in to get a sense of the audience, and then we can speak more directly to what you're interested in. Okay. All right, so largely not signed up for the program and don't have a CPT license. So welcome in for those of you who aren't as familiar with CPT. So plenty of opportunity for questions here. If you want to learn more about the program, sign up for it. It's a free sign up. Then you're welcome to do so. We'll have some links to get you in. And then poll number 2, please. So this one is, what are you working on? So are you building a new solution? Or just here to listen? Are you well underway with what you're building? Really trying to figure out how far along in the development process you are. The good thing about a lot of the resources that we highlight in these dev chats and in the program are that they help use cases either at the very beginning or all the way through to full-fledged companies. So pretty even balance here with 20-30% doing each. So that's great. That's pretty reflective of the program at large. So what we're seeing today is that we have over 2,600 participants in the program, and we've issued over 350 royalty-free development licenses for CPT content. We really want to understand what the community is working on so we can better support the different use cases out there. We typically break these applicants down in along a handful of use cases. Claim management tends to be the most popular, and rightly so. CPT is a pretty integral part to the claims process. Improving information about procedures and the clinical documentation is a big one as well. A lot of people are just still exploring in the program, which is more than welcome. We want people to get a feel for what is in CPT and how to get into medical coding before they necessarily choose a direction for their solution. And then a little bit less represented are analytics, EMRs, and price transparency. So when we look at the dev program more broadly, we highlight a lot of resources from across the AMA. We put this out around the time of our last dev chat, and this week there were a few new content aspects released by the AMA. So we'll get this updated to have more resources available. You can always check back to see if there's a change and what might be relevant to what you're working on today. These are typically split across the core CPT information, AI resources from the AMA, equity and advocacy work that we're doing, and then more broad AMA innovation type news. So lots of actionable resources there that are all open and free to consume. All right, so time for the main event. We're just like Sandeep said, we're delighted to have Ed Simcox join the dev chat. Ed's the VP of Solutions for Mayo Clinic Platform, and has a real strong track record of impact before this role. He spent time at cutting edge tech companies. He was the CTO at Indiana University Health, where they received the Hospitals and Health Network's Most Wired Hospital Award. And in case that's not difficult enough, he was the CTO and acting CIO at HHS. He ran a lot of startup focused programs there, highlighting the importance of innovation in healthcare. And so today we'll be diving into healthcare innovation, and let's get to it. Welcome, Ed.
Thank you. Sorry, coming off mute. Glad to be here. Thanks so much for the introduction.
Great. So I will stop sharing here so we can have a discussion. If I can find that. Well, as I'm finding that button, let's get into kind of a market question, just broadly. What are you seeing in terms of the types of markets where startups are playing? Are they looking to provide solutions for payers, providers, hospital systems broadly? What are the focus areas that you've been seeing?
Yeah, I think all of the above. So at Mayo Clinic Platform, we predominantly work with organizations that are creating high-tech solutions, most of which have some form of artificial intelligence in them that help with the rendering of care, right? The provision of care. So we think about early disease detection. We think about characterizing patients. We think about ways to collect data from patients before they are seen at Mayo Clinic. So Mayo Clinic is special in that it is a destination medical center type of a model. And people typically come to Mayo Clinic after they've exhausted local resources in their community for the types of conditions that they have. And so Mayo Clinic is known to be really tops at providing serious and complex care for patients, as well as care for patients that have rare diseases where there might not be specialties and subspecialties on a local basis to be able to care for those patients. So it's really important for Mayo to be able to collect data about patients from other providers and directly from the patient. So we're seeing some very interesting tools come out to help in the collection and the summarization of that information, making sure that it's as complete and truthful and accurate as it possibly can be before the patient actually has to show up on campus, because these patients are coming from literally all over the world, but definitely all over the United States. And what we would hate to do is see a patient with a complex condition and then say, hey, you've got two options. We can either rerun a bunch of tests. We know you've had these, but we don't have the results. Or you can wait, and come back tomorrow and we can see if we can possibly get that information. So we want to make it as easy as possible for our clinicians, as well as the remote clinicians and the patients that we serve to get that information, right? So a lot of the focus really that we see is on provider-centric things, some of which are administrative, like the thing that I just mentioned, going all the way to things that are doing early disease detection, helping people get into clinic quicker, helping people, finding people that have disease progression much earlier than is typically the average in the United States. So we're seeing a lot of activity there. I know of a lot of companies that are doing work with lower GI, for instance, looking at how can we do a better job at getting people in for colonoscopies? How do we use AI and statistical algorithms to create cohorts of patients for outreach so that we can get patients in to clinic using data, not just a hunch, not just kind of a marketing hunch, but actually using data to get these patients into clinic so that we can catch disease earlier. And then, of course, we're seeing a ton, as is always the case, we're seeing a ton of innovation happening in imaging. So any type of image-based pursuit in healthcare, so we've seen a ton in radiology. In fact, as far as algorithms that have been approved by the FDA, the overwhelming majority of those happen to be in radiology. And then there are a handful as well in pathology, and digital pathology is coming on very strong on the coattails of success that we've seen with radiology. And now we're even seeing full motion video algorithms that are being developed. And this is really beneficial to surgery. So general surgeries, urology, and endoscopic types of procedures where we can begin to apply AI at the point of care in the surgical suite or the endoscopic suite to help identify polyps, to make sure that surgeries are done in a safe and efficacious way, and so on. So, that's just the provider side, right? We're also seeing a lot of really interesting things coming out as far as, generative AI used to help with prior auth. When you talk to clinicians, prior auth is a big issue, and it really prevents us from getting the best care to patients. Just because of the friction associated with doing prior auth, it oftentimes is a very bespoke process. So we're seeing some very interesting things kind of coming, addressing the interplay between provider and payer.
We just had some survey information come out today around prior auth, a new provider survey. So that highlights the burdens that providers are seeing. When you said that these solutions are very, physician-centric, how do startups, find those provider needs? How are they really solving the problems that providers are looking for? And that kind of goes along, I think, with a user-submitted question about what kind of data do you look for, when you're looking to build these solutions?
Yeah, so the best thing to do when you're thinking about starting a company or you're thinking about the strategy of your company, I think a really easy place to go are associations. So AMA is a really good place to go. If you're trying to address physician burnout, for instance, right, and return the joy of the practice of medicine to clinicians, because we all know that there's a huge burnout issue. If you're trying to address staffing issues, right, find associations that poll their members, just like we did at the beginning of this call, right? But poll members that, and they publish at least, you know, portions of that to understand what are the trends, how are those trends impacting the profession, and you know, organizations like HIMSS, they do polling like this. Health does polling like this, you know, kind of on the tech and the IT side, but all of the academies and kind of the medical associations do polling of their membership as well. Sometimes they publish that, sometimes they don't, but that's always a really good jumping off point to understand where the trends are. And then of course, there are many organizations that really keep their finger on the pulse of what, say, CEOs of hospitals or heads of departments, divisions, specialties, subspecialties are looking for, as well as the tech leaders inside these organizations. Then you've got probably the same stuff over on the payer side, but I'm not as familiar with how to get at that data. So that's a great starting place to go to really figure out what's going on.
Okay. And then on the kind of competitive analysis side, you know, a lot of companies are doing things that overlap. And so there's always some kind of competitive advantage that a company needs to identify. So can you speak a little bit about how these companies can use platforms and marketplaces to understand what's in the marketplace so they can, you know, refine their value prop?
Yeah, so another great jumping off point to your point is to look at different platforms, different marketplaces that exist. Some of these are run by electronic health record companies. Epic has one, Oracle Cerner has one. The other major EHR players have them as well. And these are great places to begin to look at catalogs of solutions that are already in market, that are already being consumed by the customers of these electronic health record systems. Keep in mind that not all good solutions are going to be published in those particular catalogs of solutions or marketplaces. And the reason is because they curate those lists. And I know one of the large EHRs in particular does a really good job at excluding ones that they feel are a competitive threat to their own business, or provide, or they feel like it threatens the proprietary nature and the value of the software that they're providing, and could actually commoditize them in the future. So they're going to try everything possible to avoid inclusion of those in their marketplace. But there are other places to go as well. Mayo Clinic actually has Mayo Clinic platform, and we can get into a little bit more detail on that, you know, here. But Mayo Clinic platform is a place where we work with solution developers, you know, i.e. startups and growth companies who really want to connect with health systems, regardless of what EHR they might have. And we have a program specifically for them where we run them through a qualification process that really helps provide transparency, explainability, and de-risk the solutions for the providers that are also part of the platform. So if you think about a two-sided marketplace, like Uber or Amazon, you have, well, we'll take Uber, right? You have drivers and you have riders. And then in the middle, you have a set of tools, or what might be considered software products that Uber owns and operates. And they've created a sense of trust between the two sides, and that's how they've become successful. Organizations like Mayo Clinic and with Mayo Clinic platform are doing the same exact thing. So we're creating a set of rails or a set of products between solution developers and healthcare providers that reduce the time, reduce the friction, the legal friction, the cost, associated with contracting, doing security reviews, et cetera. By doing things like that in advance and having folks on both sides of the market agree in principle to a set of terms and conditions in terms of operation to then get to reduce the time to value in the friction and the cost associated with conducting business. And so that's just one example of platforms and marketplaces that are out there. But again, there are many different places such as Mayo Clinic platform where you can go to see what others are doing. And I would say, don't be afraid if you see organizations that are doing things that are very similar to yours. I know at Mayo Clinic platform, we don't put our finger on the scale and say, hey, we just chose a startup for this category. For instance, early disease detection for lower GI, since I used that example before. It's an open marketplace, and so we fully intend someday. We don't have it today, but we fully intend probably see some overlap in the solutions that are there. And there's no better way to learn about what others are doing in the market and to improve your own product and create that market differentiation that you mentioned in your question, than to see what others are doing that are similar to you.
That totally makes sense. There's a user submitted question is an interesting spin on it. So marketplaces are a way for startups to get a leg up and connect more rapidly into an ecosystem, right? And they're asking how long it takes a new provider to be fully productive at Mayo, given all the system complexity. Do you think that the marketplace concept is helping providers, get into the workflows more readily? Is it kind of a benefit on both sides?
Totally. So in roles that I've had, for instance, CIO roles, I can tell you the way CIOs think. And this is just CIOs, but other people inside the health system are going to have similar viewpoints. And so in the payer world or the provider world, it's full of red tape and bureaucracy. We're the most heavily regulated industry, except for maybe nuclear energy. Some people say fintech or financial services, but I tend to think after my time in Washington that healthcare is probably more heavily regulated. You throw in the complexity between the patient provider, the patient provider and payer relationship creates more complexity as well. But anyway, so providers are, it's very difficult for them to consume solutions that say a surgeon or some other type of clinician might be interested in bringing into the organization, and the CIO would be interested in supporting. It's just very difficult to go through all of the legal things. You got to go through the legal committee, you got to go through the risk committee, you got to go through the cyber committee, and so on and so forth. And so it just becomes a inverted calculus where, as a CIO, I would say, well, how much is the solution? Well, a solution is going to cost $50,000 for a year. And I would say, heck, it's going to cost us that in time just to do the legal work, just to get the BAA cost startups, $30,000 sometimes, the back and forth and things. So if we can reduce the friction, the business friction, by creating pre-staged contracts that are agreed to on both sides, which is something that Mayo Clinic platform does very well. And we can provide technical interfaces in the form of open APIs that become almost intermediaries or brokers between the sides. And solution developers can code to those APIs very easily because we're speaking their language and we're publishing really, really good documentation and supporting them in that effort. It makes it much easier to consume on the provider side because the provider doesn't have to apply a lot of technical expertise, legal, risk expertise, and so on to bring that $50,000 solution into the organization. So it really lowers the barriers to entry. Anybody that's been around the startup world knows how difficult it is. Sometimes you're you know, your first sale is easy. Maybe you get super discount. They're a super user. They're an MVP client. They're using their know-how to help you develop your thing, and they become a reference. It's clients 2 and 3 that are the most difficult and the most expensive a lot of times to implement. So we see a lot of you know, solution developers are saying they see a lot of value in our programs because we're able to reduce all that friction.
Right. That's getting to that chasm area, you know, where the first ardent supporters are kind of easy to pull on, but then once you're trying to scale up, that's the hard stuff. So it does sound like, you know, these platforms are more accelerators in that growth period. And the last guest that we had echoed the sentiment around CIOs thinking about, you know, you've got thousands of startups and companies trying to connect. How do you whittle that down to a manageable number? And so it sounds like the Mayo Clinic platform is taking a big step toward that.
Yeah, you can I'm sorry to interrupt you, but you can kind of think as, you know, organizations like Mayo Clinic platform as a single contract, right? If you're a CIO or you're a business leader inside of the health system. So even though you may have, you know, multiple solutions from multiple solution developers, you're really only having to do your contracting and everything one time, and then you're just adding a statement of work or a miniature service agreement under a set of standard terms. It makes it much easier to get done, and so you can actually exercise what we call portfolio management in the IT business a lot easier, because you can have a single pane of glass of all the solutions that are running in the context of, say, Mayo Clinic platform.
Okay.
Yeah.
One of the things that I wanted to touch on was your background is heavy on innovation and security. So how should these companies be thinking of, you know, how much effort to devote to security versus building out those innovative features to attract potential customers? What does that calculus look like to you?
Well, obviously you have to figure out what your one thing is, right? So what's your elevator pitch, your 11-second elevator pitch? Stay true to that one thing, and then build your features accordingly, right? Create your development roadmap, your feature roadmap accordingly. Be ready to change that as you learn more about the market, what's hitting right in the market, what's not, what your competitors are doing, and so on. Look for opportunities where a little bit of development creates a ton of value. So that's kind of how I would, you know, think through a development roadmap in a startup. Be careful to always, I'm going to repeat this, be careful to always figure out what your true north is, your one thing, because what I've seen a lot of companies do is chase shiny objects. I've seen a lot of companies recently start talking about Gen AI all of a sudden, and I know the founders of these companies, and I know the software that they've developed, and it really doesn't call for Gen AI. And so are they going to spend all the time, effort, and money chasing a Gen AI version or flavor of their solution or integrate it, when they should really be focused on what has brought them to market already, right? And I'm not saying people shouldn't chase Gen AI. I'm just saying go eyes wide open and make sure you make a strategic decision about those things, but always staying true to whatever your one thing is that you're developing. As far as security, it's really important to code with security in mind at all times. Think about, you know, cybersecurity as code. Think about compliance as code, auditability, transparency, traceability, all the kind of fundamental things that we should be thinking about as we are building whatever it is we're building. Use as much open source and standard technology as possible when you're building as well, that's well documented and cared for from a community perspective by a really strong and fervent open source community, is something I always recommend people do as well. and then finally have an understanding and a fear of the various laws under which we have to operate when it comes to patient data, right? So predominantly HIPAA, but there are some other ones as well that are definitely worth understanding.
Mm-hmm. I know Sandeep's chomping at the bit to get into some AI stuff. One quick lead into that, your thoughts on, find your one thing. Remind me of a company that I heard pitch, and they were adamant that they were not blockchain. The blockchain business in healthcare was kind of another fervor. And it was hilarious because this company kept saying, we're not blockchain, we're not blockchain. It's like, well, then why are you talking about it? And it's good, like, that you're not using blockchain in a case that doesn't need it. But be clear about what your value prop is, what you're bringing, and how that relates. And so, when we are talking about Gen AI, you were at an AI and RPA panel in 2019. So any thoughts on what the difference between the thinking around AI was at that point versus now?
Yeah, I mean, so I did a lot of work in the federal government to help reduce red tape, reduce manual processes, reduce costs associated with various processes in federal government that could very, very easily be automated. The wonderful thing about being in the federal government was that there was so much low-hanging fruit. There were literally people walking around HHS with papers in their hands, and they would walk a route every day to get signatures and stamps on pieces of paper. I'm not kidding. So low-hanging fruit, right? So we started looking at RPA and started implementing RPA, and ended up saving the government a bunch of money in the process, and more importantly, made the citizen experience and the experience for providers who were dealing with CMS more automated, more streamlined, more user-friendly, and that we saw real benefit from that. And this was not super duper fancy technology with Gen AI built in and all this. This was just simple automation techniques that vendors had at the time. Go back to your point about blockchain. So when I was in federal government, blockchain was the big thing, and all the CIOs in federal government and the CTOs were, getting hand wavy about blockchain. Fast forward to today, there's very little blockchain that has been implemented in federal government. There was a bunch of money poured into it, and most of those projects have gone by the wayside. Guess what's replaced it? Conversation about generative AI and large language models and small language models and RAG and so forth. And that's great, but I hope we don't repeat mistakes of the past and just a lot of times these newer technologies, we see these cycles, they're typically 4 years or 5 years. This one is different, definitely different. The generative AI one, it's much more sticky and has broader applicability, but we see the same behaviors at the front end of these curves, where people just jump headlong into it and say, gosh, we've got to do something or we're going to be behind. And I just always caution people, always give a really, really healthy dose of skepticism before jumping in like that. We don't know how these models are going to perform even in 6 months. I mean, the performance is really getting much better. We're seeing smaller models performing as well as large models. They're easier to consume, they're easier to train, those types of things. So it's really important. But how has AI changed? We talked a little bit about RPA. Obviously, the Gen AI thing has eclipsed what we used to talk about, which was supervised learning, right? In federal government, we used to talk about supervised learning. Unsupervised learning, not so much, except within the NIH and a little bit within CDC. So some of the institutes within the NIH were doing some pretty interesting unsupervised learning, especially around cancer. but it was really kind of very researchy and almost after school projects, if you will. Fast forward to today, Gen AI is being consumed at a very rapid pace within building one at NIH, so the administrators building, and then on down into the ICs at a very rapid clip. And I don't think that's going to stop anytime soon. And so yeah, we moved from kind of your traditional artificial intelligence conversation to Gen AI very, very quickly over the last couple of years here.
Yeah, that's great. No, thanks for sharing those insights. And yeah, I think expanding upon that, right? Like the technology has evolved a lot, made a lot of things possible, making almost AI app development mainstream is what Gen AI has done in past 12 months, sorry, or a little more. And you have a different view, right? Like you've been in the industry and you've seen so many problem areas, and even from a marketplace perspective, just your personal opinion, like what use cases you're most excited, or you kind of seen in action and that you found promising, would be kind of nice for our community to know, like what, from your vantage point, what you think would be the use cases / applications that might be really interesting to see.
So you mean applications for Gen AI?
Yeah, Gen AI or general AI too. Yeah.
Yeah. So there's so much we could get into here.
Maybe pick your 1, 2 top.
So maybe we need to look at, what the needs are in healthcare, right? So let's talk about what providers are feeling, especially after COVID, right? Staffing shortages, right? Now, this has started to be addressed in a very meaningful way, but I can tell you that there are small systems here. I live in Indiana. There are small systems here that are desperate for nurses and every other type of licensed professional. And they're spending much over more than their budget allows to get professionals and conduct medicine in a safe and efficacious way. So we still need to work on that. Burnout, right? Physician burnout is awful. The AMA knows this. The AMA is addressing mental health issues of clinicians, and I applaud the efforts. The American Academy of Family Physicians doing the same thing. We're seeing increasing suicide rates among primary care physicians and specialists as well. And this is a big problem in our industry that we need to continue to address. So those of us that are developing solutions need to figure out how can we return the joy of the practice of medicine to our clinicians. These are physicians, nurses, technicians, and so on. That is a huge area, and I'm seeing a lot of very interesting things come out. We need to follow clinicians around, physicians around the hospital or their practice and see what bugs them. Because sometimes we think we have the answers and they may be right in front of our face and we may be missing it. I've had very interesting conversations just recently around prior auth, for instance. When you have a decorated Mohs surgeon, which is a skin cancer surgeon, very specialized techniques and so on, who has to step away from the OR to do a prior auth for a patient that needs to be seen that day or the following day, that is a big problem with the system. And it creates a ton of stress in their life because they're worried about the patients, right? So things like that we kind of miss. So I'm seeing a real uptick in things that help address clinician burnout through reducing administrative stress. Reducing claims denials is an area that's a big deal, right? So we can reduce our average receivables, average length of receivables. And I know a lot of folks probably, here on this call are thinking through some of that. But those are the big things: burnout, prior auth, claims denials, and then of course we're seeing a ton of pre-diagnostic stuff, so what we call early disease detection, and a lot of those solutions will end up being solutions that can grow and mature and eventually go through the FDA process and become, quote, diagnostic
Right.
in the future through the software as a medical device program within the FDA.
Yeah, no, those are great insights. That's awesome. Because yeah, I was also thinking about another thing, like what trends you see in the provider needs, but this kind of covers it. Like the problem areas that you're identifying are the provider needs to kind of make them more productive, and that's where technology can be most helpful. Yeah, that's great.
We're
Cool.
seeing generative AI solutions pretty much across the board. Sepsis is a big deal, right?
Mhm.
And we probably heard about some of the controversy associated with the sepsis algorithms that have been delivered by the large electronic health record systems. If not, it's worth a study. But there are some new sepsis solutions that are lightweight, easy to integrate at the point of care in the inpatient setting, and provide a much quicker way to identify patients that are about to crash than what we see today. Just as an example, there are MedSitter type applications where we can watch patients from a distance, and the AI can actually watch patients from a distance and only surface patient needs to nurses and other caregivers at the right time, and really reduce alert fatigue, right? So alarms and bells and whistles aren't going off unless absolutely necessary, unless the AI agent needs to actually escalate those things for a safety or a comfort issue for the patient or whatnot, right?
Yeah.
But we're seeing things for primary care practice. One of the fascinating areas of growth, and I think this is a great application of generative AI, is kind of the new age chatbots that are coming out. So I know of one company that has an ambient listening app that all you need is a smartphone, right? Or you can use your clinical machine as well.
Yep.
And I actually got a demo of one of these ambient listening applications recently in a loud restaurant, and we were right in the middle of doing a mock patient encounter with doctor and clinician about strep throat. And the waiter came up to the table to take our meal order, and everyone stopped. There were 10 people at the table. We gave the meal order, went right back into the conversation, into the patient engagement conversation. And when you look at the transcript, it blocked out all of the extraneous voices.
Wow.
Literally picked up from the last word to the next word that was spoken as part of that encounter.
Jonathan, how are you? Oh, it could be better.
Somebody is unmuted here.
Here's that Tanya.
I think that's great.
Well,
all right.
Well, on top of that,
yeah.
Oh, go ahead.
No, I just had one follow-up question from a solution development perspective, but those are like great examples. And thinking from a platform perspective, are any suggestions you have for solution developers that are looking to build with AI to solve some of the problems, particularly with security in mind, or any AI guidelines in mind that you're thinking about, like any resources or any general things that you're seeing in the market? Yeah.
Yes, absolutely. So there's a lot of conversation in Washington and within the healthcare circles around safe and efficacious use of artificial intelligence, and how do we create guidelines and guardrails. And the hope, I think, of the industry is to kind of to come out with a self-regulating mechanism whereby the industry can regulate itself, and we don't have to rely on Congress to come out with some sort of draconian or arcane, rigid guidelines that really stifle innovation and create additional risk without really solving the issue. So one of the, and by the way, there are a lot of people in federal government who are looking for the industry to do this. So there are a ton of leaders that are working on this very issue. I'd recommend everyone go check out the Coalition for Health AI, or CHAI, as it's called. What's interesting about this particular effort, as opposed to some of the other ones within healthcare, is that it actually has ex officio members from the federal government, meaning they're not really official members, but they want to contribute their thoughts and they want to learn from this group and this organization. And actually, Troy Tasbaz at the FDA and other leaders are picking up best practices and tidbits of information so that they can eventually get that stuff into regulation where it makes sense, right? So it's really the federal government listening to industry. So they've come out with the Coalition for Health AI has come out with a rubric and some best practices around responsible AI use and development within healthcare. And I recommend everyone go check it out.
That's great. Thank you.
Fantastic. Yep. So let's open it up to some participant questions. Griffin, I see you had a question you'd like to ask.
Yeah, am I allowed to speak? Can I just unmute and speak?
Sure. Yep.
I feel like, I guess, with AI, that there's a lot of hesitancy just because it's artificial intelligence. Does intelligent automation resonate more with people nowadays? Intelligently automating teams, for example, like a CPT coding team, instead of getting rid of them and having AI replace them, allowing them to become like auditors in a sense and intelligently automating them with our systems. Do you think that would resonate more on the healthcare space rather than just completely having a computer take over the experiences and job that they provide?
Yes, this is obviously a touchy subject and situation, and we actually saw real resistance within the federal government to doing RPA until people realized what it was doing was actually, it was a job aid, and it was automating mundane and repetitive tasks. And what we did is we made sure that people understood. We actually offered upskilling to people whose jobs were then going to be partially automated by RPA, right? It didn't come out of their cost center or any of that. And so they could get upskilling in dozens of different things, either classroom led or online, because we were committed to upskilling people and getting them away from doing these mundane repetitive tasks and returning the joy of work to them. Because I don't think anybody wants to do the same task 40 or 50 times a day, right? So when we talk about claims and billing, can we do the same thing there? Can we augment what's going on and get rid of the annoying parts of folks' jobs and allow them to focus on other higher order tasks, right?
Absolutely.
That's definitely something to think about. And then, of course, that has to flow down into the marketing, right? And then the messages that are given to leadership that it might be making a decision about these types of tools, and the people on the front lines needs to reflect in a very honest way, where we want to be honest and earnest and forthright about what's going on here. And I think if you do that, you can develop a level of trust, right? And each culture is going to be different, right? Some cultures you go in and they're not going to be interested at all, and you can ferret those out pretty quickly and just say, hey, we're not going to qualify this as a sales qualified lead. We're going to go somewhere else.
Yeah. Am I allowed to just throw another question out there?
Sure.
I think that's something we've been looking at is like the gray matter of healthcare. So in document quality analysis, how much has that resonated with people coming to market with systems like this, especially in CPT and documentation? Have you seen a lot of people focusing on what's not there that should be, or what has that been something showing up at all?
Give me an idea about what.
So let's say there's documentation in a patient's EHR from a couple years back, or let's say 6 months back, and they came in for another appointment, and AI is able to understand the doctor's notes and say, hey, we should be coding at this level, although from what it seems like you missed providing this in the last couple patient visits, and so we can't code at this level because of these reasons. Is there a lot of companies looking at that gray matter that's not there that should be? I guess I'll allow you to kind of build on top of that as well.
Yeah, I've got to assume, I have to assume folks are running at that problem. I don't know of any companies in particular that are, but obviously, people want to be as accurate as possible in coding, and maximize reimbursement, right, in an ethical way, right? So, in the collective knowledge of the institution can be leveraged, as far as past documentation and data and things. So I think that would be a pretty interesting thing to say. The head of revenue cycle inside of a hospital system, or the CFO, and probably down, I mean, I'm going to assume down at the kind of the primary care practice level as well, right?
Mm-hmm. I appreciate
I've
that
seen
answer.
I've seen it show up in a few different ways. One is around, in the visit itself, you're performing certain things, and then is there a gap in what you would need to code for a particular CPT code? Like, if you're saying that it's one level, is it, is there something else that would bump it from a low complexity to a moderate, something like that, and decision support in a visit. Also around, if you're submitting a prior auth request and you're trying to think about what documentation is required, finding those gaps, that might be more of a process thing, like why is this information missing in this case, and how can we improve it going forward? And then I had another one too, but yeah, so I think there are people attacking this from different angles, and it's a little bit nuanced in what they're looking for, and how to get it. And so I don't think it's like a one size fits all approach to it. But certainly one of the tougher aspects to understand the context of the situation and suggest that you ask a certain thing. Oh, the third piece was when payers are expecting certain things to align with their policies, they may want to inject some kind of, hey, you might want to also order this lab test. And that starts to get into murky waters, but it is another one of those, gap areas that that people are practically looking at.
Absolutely. I appreciate that answer as well, sir.
Sure. Alden, do you have a question?
Thanks. How do you think about solutions that are more maybe back office, like provider credentialing, provider quality, versus more care operations? So like workflow adherence, tele EMR, like how do you think about those as opportunity spaces, or just like general excitement?
They resonate, it depends on who your audience is within the health system, right? But if you can get to the right folks where things of that nature are important to them, you can assume you're at least going to get an audience with, at least initial interest for what might be offered. Obviously, the messaging is going to be different. So messaging in that case is going to be different than claims adjudication and prior auth and things of that nature. And of course, it's going to be different than direct patient care or population health management or decision support. So it's really, I think, there are definite opportunities, and sometimes there are corners of hospitals that don't get a lot of attention because people might be chasing sexy things and trying to get big VC money and things of that nature. But the unsexy things a lot of times can be the most profitable and the most beneficial to the health system. So I highly encourage people to look across kind of the operational landscape of hospitals and figure out where they can plug in and help.
there's always an audience, right? So that's why there are so many different conferences. And if you're not talking to somebody who's excited about your solution, you probably just need to find a different audience.
And credentialing particularly has been a pain point that even AMA has been honed in on, and want to really help that problem area to be solved for helping physicians see patients faster. So that's been one of the areas that we've been looking into, and I see a lot of new players and some VC money also flowing in. So yeah, some of the operations is getting more attention and love these days. So yeah, exciting.
I just started a job yesterday at a credentialing company, so I'm like jumping into the deep end trying to understand it.
Yeah, it's great.
Well, we can take another question, but I also want to give Ed a chance to highlight any references, or we've had some people in the chat ask about where can they connect the APIs and learn more about the Mayo Clinic platform. Any kind of direction you want to send them?
Sure. Yeah, you can go to mayoclinicplatform.org. Mayo Clinic platform sits inside of Mayo Clinic, but we do have a separate URL there. And you can get an overview of the various programs that we have for solution developers, as we call them, within Mayo Clinic platform. For solution developers, we have a really cool program called Solution Studio, which it has multiple pieces of benefit and value to solution developers as they are readying their products for market, and they're seeking market entry, if you will. And so highly recommend people go check that out.
All right, fantastic. Any closing questions for Ed or for the program more broadly?
No, but I appreciate you gentlemen immensely. Thank you all for being here. I hope I can join again sometime soon.
I have a question.
Sure.
A question
Sure,
I'd like
go ahead,
to know. I'd like to know if there's any possibility of helping Mayo with any of their projects. We have a team of about 10 developers, and just going to make a shameless plug. We are very good at creating ChatGPT type clones and connecting to large language models and helping train them. There's a very informative discussion, and I really look forward to helping our very stressed healthcare system. I've met with a lot of practitioners who are very, very frustrated with the burden that they have, administrative burdens that they have, and they have to take home a lot of work, and they have to code ICD-9 and ICD-10 codes that were done incorrectly by previous physicians. And my aim is to be able to help those physicians regain a part of their life that they did not sign up for when they went to medical school. And that's just my 2 cents. But I would love to continue to participate in these discussions and offer our help to Mayo.
Yeah, thanks. We actually have a whole vendor certification process and everything that's completely outside of my span of control.
Sure.
and scope. So I really can't speak to what opportunities might be there in Mayo proper. And I know that we're really not looking for any talent at this time within Mayo Clinic platform.
Okay, thank you. Appreciate that.
You're welcome.
Well, thank you very much to Ed. Thank you to all of our participants. We love having these chats and getting questions and having these discussions. And we look forward to having you join again in the future. So,
Thank you.
Thanks so much.
thank you all.
Thank you. Thank you, Ed, so much again. Thank you.
Bye.
Bye.
Thank you very much.